All right. Hey, everybody. Welcome to this Monday episode of the Coding and Compliance Roundtable on the Compliance Guy. I'm Sean Weiss, and as always, I want to begin by saying thank you all so much for tuning in, logging on, and just hanging out with me and my friends for a little while as we get an opportunity to talk about coding, compliance, auditing, billing, and what is it that makes people think they can just do whatever they want when it comes to coding and billing and compliance, and there's no ramifications for that. I don't understand it. But I do want to talk today with our esteemed panel. I want to talk about evaluation. Yes, as Paul looks over his shoulder. I want to talk about evaluation and management services first and foremost, because prior to getting started here today, we had just a little bit of a conversation about evaluation and management services and why folks believe that they don't need a history or an examination in order to bill for an E&M service under 2022 guidelines. Can't figure it out. Number two, I want to get into a conversation about telehealth services. Telehealth is something that is a problem. And it's going to be a problem long after. Oh, wait a minute. President Biden said the public health emergency is actually over. So now that the White House has declared the public emergency is over, our industry is going to have a lot of problems with telehealth. The reason why is people haven't documented it correctly. They haven't recognized that there's a difference between interactive and audio only. Third topic that I want to talk about today is Incident 2 services. Please don't disconnect, because I'm telling you, when we start talking about Incident 2 services, some of the misperceptions that I haven't even had a chance to get to yet. And I'm going to kind of give you a little bit of a teaser to keep you hanging around. Physician billing incident to another physician. Can you or can you not do it? Hold on before you shake your heads yes or no. Number two, do you have to have your PAs or NPs credentialed in order to bill incident 2 under a physician? Again, before you shake your head yes or no, don't do it, because you're going to be shocked when you hear this answer, because it is not coming from Chapter 15, Section 60 or 60.1 of the Medicare Benefit Program Manual. It's actually coming from the Code of Federal Regulations, 42 CFR. So hang on to this. It's going to be a little bit of a roller coaster. For those of you that are my age or slightly older, if you remember the Great Space Coaster that was on every single morning prior to going to school, we're going to be feeling like we're on that roller coaster ride today. So with that said, Paul Spencer, good morning. How are you, my friend?
I'm good, and for the record, I watch Bullwinkle, so I'm going to picture
Rocky and Bullwinkle,
a snowball getting bigger and bigger and bigger as we roll down the mountain as we discuss these topics today.
That's right. Guten Tag, Mr. Kraft, who is joining us from Berlin, Germany. Yes, he is. He is over in Berlin, Germany.
That's correct. And now I have the space coaster playing in my head like an earworm. But yes, I am in Germany. This might be the first international appearance on this program.
Captain Kangaroo. Oh my gosh. Yes, I saw Captain Kangaroo. Mr. Green Jeans. I remember that. See? All right. Good morning, Terry Fletcher. How are you?
I'm good. I'm just rearing up to be the person that says, well, actually, Sean. So go ahead, Sean. Let's go.
And finally, Miss Christine Hall. Good morning.
Good morning, Sean. How are you?
All right. So I'm so excited to have all of my friends joining us today. Let's go ahead and jump straight into this thing. And I want to talk about evaluation and management services first. So really interesting. This past week, I as I said, I was in Colorado, I was in Oregon, and I was in Texas. And there was no shortage of things that were stated to me at these conferences by individuals that made me just kind of pause and think before I opened my mouth. So, one of the things that happened was an individual brought with them some progress notes from their provider, because their provider said, hey, that guy, Sean, is going to be speaking at this conference. Can you bring this with you and have him take a look at it? Well, here's the first problem. If you're going to do that, could you please make sure that you de-identify the notes? Do not remove documentation from your office or your hospital that has the patient's name, date of birth, social security number, medical record number, or any of the other 20 identifying aspects so that we can figure out who they are. Number two, in order to bill for an evaluation and management service, a 99202 through 99212, based on the 2021 E&M guidelines, you are required to have a history and physical exam that is pertinent or relevant to the patient's presenting problems and age appropriate. If you don't have a history or an examination and you only have time, or you only have some things that specifically say, I ordered this or I ordered that and I wrote the patient a script, that is not going to support an evaluation and management service. So let me pause and let me go ahead, and I'm going to, Paul, I'm sorry, I'm going to put Christine in the center box first. Christine, let's talk a little bit about the requirements of evaluation and management services under 2021 E&M guidelines.
Absolutely. And I don't know how we thought that, since from a coding perspective, we don't need to calculate or count or quantify that history and exam component. Where did that translate into? We don't need it at all. So we don't know why the patient's here. We don't know what the facts are. We just know they have this condition and we're going to give them a drug. Might be getting better, might be getting worse. We'll never know, right? So the huge misconception, and I hear that all the time.
So, Terry, when it comes to evaluation and management services, and so we've talked a little bit with Christine about having a history and examination. One of the other things that I think folks need to also recognize is that in addition to time or medical decision making, you also have to meet something called severity or medical necessity, because section 30.6.1, if I'm not mistaken, of the Medicare Program Integrity Manual specifically says medical necessity is the overarching criteria in addition to the individual elements of a CPT code. So is it fair to say that if we don't meet the medical necessity, because AMA guidelines say it's medical decision-making or time, if we don't have medical necessity, do we support an E&M service?
Well, no. I mean, that's the short answer. But one of the things I just wanted to include in what Christine said, auditors like ourselves have a little bit of a challenge. Well, it's a lot of a challenge, because the CPT, so AMA, and which CMS agrees with, says that there needs to be a medically appropriate, it says it's required, a medically appropriate history and or exam before you even move on with the medical decision-making or time-valued service. The problem is, here's where the challenge is. There's no standard of what that exam or history has to look like anymore. There's no review of systems. There's no, not saying you don't need it, I'm saying there's nothing to check a box anymore from an auditing perspective. And even when you move into the shared split visits in the hospital, when it says that substantive portion, and they have to complete, if they're going to base it on documentation and what they're doing with medical necessity, then they have to complete either the history, the exam, or medical decision-making in its entirety. Well, if you don't have a standard of care for this exam or for this history, what does that mean? What does it mean to complete it in its entirety? If you've got a physician out there that says, do you have a family history of colon cancer? And the patient says, yes, I do. Okay, great. And moves on. Is that enough? If basically the patient's coming in because they've got, something that says they have a positive stool. So is that enough? And then did they complete it in its entirety? So we have a challenge there because there's not a specific guideline on what constitutes a required or medically appropriate history or exam. So it's really hard to, I don't want to say argue with a physician or a provider, but state our case as to what is medically indicated to move on with ordering tests, ordering services, working up the patient to that medical decision. Because if we don't see something, if the patient's presenting with a certain problem, we're kind of making assumptions of what that exam or that history should look like. And they're like, no, I'm the doctor. I'm telling you what it looks like. And we're like, well, that's really nice. But when you come in with an ankle fracture and we're seeing a chest x-ray, that just doesn't help us here. And they're like, but it says whatever I think. That's determined by the physician. So this is where we have a challenge when it comes to that.
The encounter that I've had recently this week was the all or nothing conversation. So we went from these 16-page notes that talked about every possibility that the patient might have, AKA every box was clicked in the EMR, to, wait a minute, I don't need any of that anymore. So it was all or nothing. It doesn't make any sense to me. How do we get back to, wait a minute, like you were saying, Terry, why don't you just tell me the story? Patient came in for this. Here's what we looked at. This is what they said. Let's get relevant. It seems like we can't seem to find that happy median there. It's either I'm going to click all the boxes or I'm going to click none of the boxes. What about the boxes that are relevant?
That's a great point.
I have an idea. So,
we'll take it.
At the beginning of this entire process, let's throw out the 95 and 97 guidelines. Let's go back to the beginning. And we go back to, again, I keep saying his name, but Dr. Larry Weed and the problem-oriented medical record. And the way that was supposed to be structured, I mean, it evolved into the SOAP note, but there needs to be a clear definition of the problem. There needs to be data to support the definition. There needs to be what is being done to try to solve it. And the note needs to be thorough, reliable, analytically sound, and efficient. That was the philosophy. And every doctor is taught that, at least they were, but we now have a very tech savvy generation of providers that are coming on the scene that want to abbreviate everything for time savings. So the SOAP note has become the APSO note, where we do the assessment and plan on the first page, and then we treat the history and the examination as, there's this other stuff too. Well, the science of medicine doesn't work like that. The science of medicine is, look at the symptoms, examine the patient, identify the problem, recommend a treatment course. And it's always, and the 24-year coder should not be the person telling the doctor that. The doctor should know that.
So I like this question that was asked by Cairo Medicare, which is, wouldn't it be appropriate to use the older E&M guidelines for the history and exam requirements? So for me, my natural response would be, in the absence of anything more definitive than what we have in the AMA and from CMS, which is a clinically relevant and age-appropriate examination in history, I think if you're looking for some specifics, I think it's fine to revert to those. But remember, they're not giving you credit, if you will, based on the individual elements of those history exam elements. Scott, any thoughts on that?
Yeah, I think, you certainly could use, like when I saw that question, my thought was, well, it wouldn't be inappropriate, but it would potentially be excessive, and it would potentially bring about a lot of the things that caused us to make this Obviously there's not a straight guidelines requirement anymore, but I used to struggle with the rationality of explaining to psychiatrists or orthopedists, these crazy comprehensive exams they would have to document. And I would say, well, you missed and have a comprehensive psychiatric exam when it was really irrelevant. And I think Paul is leaning into a good point. Like these guidelines, I've said it when I talk to the providers that I work with, these guidelines were a great opportunity for you to strip all of this, I'll say, that you don't need to put in there, that causes contradictions, that causes conflicts, that's, heavily EMR laden. We all, all of us amongst ourselves question whether the work has actually been done, and just gives you an opportunity to just explain in a very straightforward way what's going on. Medically appropriate history and exam. I may see a patient or I may review a chart of a patient who is coming in to discuss treatment options because that patient has had some sort of result on a diagnostic imaging or a lab test that's indicative. And so there doesn't necessarily have to be some big exam, right? It might just be the history that has led us to this place. And now you have the latitude of doing that without saying, well, I'm going to go ahead and do a head-to-toe exam. And I think half the time the provider was doing that, they were afraid that somebody like me was going to come in and say, well, you missed fund of knowledge, and so you can't have a comprehensive exam. And so, I think to tie it all together, just say what's happening. I think Terry, one of the things that Terry had said that resonated with me is I feel somewhat uncomfortable in my non-clinical role, physicians what to examine. I feel somewhat uncomfortable telling them what history to take. But there's a difference between that and like no history. There's a difference between that and no exam. And I sometimes frame it to the provider as a lot of the severity when we look at how we think about, is this a exacerbated chronic problem? Is this chronic versus acute? Is this severely exacerbated? A lot of this flows from the history and exam, and not just because you think it's that way, but you didn't properly convey it.
That's right. So, I want to go back to Chiro Medicare for just a moment. I knew exactly what you were saying, not for taking the credit for those elements, but using it as a reference point to be able to make sure you capture clinically relevant aspects of the history and or exam. So I'm with you 100%. I see a lot of great, comments, and I'm excited to see how active everybody is. Terry, one of the things that you brought up a moment ago was the fact that providers, and I don't know whether the blame lies with the provider group or it lies with the EMR, but their templates are the same now as they were prior to.
They haven't updated. I know a lot of like NextGen and Epic, they're charging for the update. They're not making it an automatic update. So their physicians are like, well, it's fine. We'll just go back through and just use what we have. And since you're not using the exam or the history, we'll just fill it in as we ever did before. And it also, a lot of practices said it saved us on retraining them what to do. I'm just like, oh boy. But just to add on to what Scott was saying, one of the things that I try to explain to physicians and providers, because obviously the mid-levels are in here too, is that the thing that I think that AMA took out the scoring, if you will, of the history and exam is because as an auditor, we would see a really pretty level 4 or 5. And if they'd miss one element of that past family social history, we had to back them up to a level 1 or, a level 2. And so that's what I think they were trying to say, is that you have a pretty substantive record. And if you miss one little, scoring element in that history, you're back to, losing almost 150 or less or more dollars. And so I think they tried to eliminate that, which I appreciate, because that was so painful when I had a doctor saying, how can you tell me that this patient wasn't level 5? I'm like, well, you only had 2 out of 3 of the past family social history. So, they're just like, oh, what?
You mean you
that,
forgot the family history on a 95-year-old patient? What were
exactly.
you
And so
thinking?
that was a problem. Or I'd see
Well,
physicians
there was a
that,
certain irrationality to the previous history and exam requirements in many cases. And I
yes.
think, you know, when you ask people to do irrational, dumb things, at a certain point, it becomes very frustrating and it becomes very difficult. Even as this system may become more rational, they're sort of rooted in irrationality. One of my favorite stories from the 95 guidelines is I worked with this gastroenterologist many, many years ago. Did very well in his audit, but as I was reviewing the charts, the thing I kept noticing was he did not actually ever in system as part of his exam. Now, he always met the 8 organ systems examined requirements. And so I'm going through this and I'm like, well, I feel compelled to ask, like, as a gastroenterologist, it seems, you know, I'm not the clinician, but it seems a little strange to me that you would never do a gastroenterology. And his response to me was, well, my understanding is I have to do 10 organ systems, the review of systems, and 8 organ systems in the exam. And so in all likelihood, if I ever have to make a change to my documented exam or my documented review of systems, it's going to be within GI. So I just don't document. So I'm sitting here, he's basically telling me, well, this way I never have to change any of this stuff.
Oh my gosh. Well, and I get the ones that say, well, what do I need to do since I'm only hitting 7 systems, which was almost every audit for a long time, to get to 8 systems so I can have that comprehensive history? And you don't want to tell them that because, like Christine's point, okay, why are you doing an eye exam if you're coming in for, you know, rectal bleeding? This doesn't make any sense to any of us. And so they're just like, well, because again, the scoring said if I add that extra system, I can have that higher level. So now fast forward to the 2021 and soon to be 2023 rules, we're running into some issues again because we don't have a clear definition of the medically appropriate history exam, but we still have to have it. And I think people are missing the point. It's not that you don't have to have it, it's that we don't use it to score or to level your service. But to Sean's point of medical necessity, let's say that your medical decision making did meet a level 5, or let's say that you had, and I always hit level 5 because that's highly audited, or let's say that you had your 40 minutes or 60 minutes, whether new or established, to hit the level 5 service on time, but there wasn't a medically appropriate history exam, or it didn't even exist. Do we still give you credit for that visit? No. So it's not that we use it to level it, you still have to have it. And that's where I think there's a problem with understanding that.
If you think it's fun now, wait until acute care. And
Yeah.
there's no difference between an admission to observation versus an admission to the hospital for
Which I don't
coding
get that,
purposes. That's going to be
I
ugly.
think that's a great point. Yeah, that's a great point, and we're gonna hit that probably next week because we're getting closer now to getting ready to get into 2023. So
Well,
I was
I was
gonna
going
wait
to
to
jump in
do
real
this.
quick, Sean. I'm
Yeah,
feeling a
go
little
ahead.
spicy today. So just to kind of wrap up what we're talking about here, call me naive, call my friends at AMA naive, but I really feel like they thought that providers and coders were going to get together and they were going to discuss what is medically relevant, right? That they were going to say, hey, when I see a patient, this is what I think is medically relevant. As a matter of fact, the ICD-10 guidelines even added a whole paragraph to say, get together, guys, and the providers and the coders so that we can select the proper codes, not just for ICD-10, but hey, we're going to make some changes to E&M too. Get on the same page, folks. Unfortunately, in the real world where we all live, that's not what kind of happened. And so I think that might be contributing to some of the challenges that we're seeing right now.
Well, and I think, you know, I think the coders probably feel the way a lot of us do. We've all been in those situations where, you know, the doctor's perception is that we are stepping into the terrain of, you know, clinical, and they're just, as they shut that down, you know, the coder, and I think that, frankly, I think that has a bigger, more chilling effect on people like me, right? Like I come in, I do my thing, I go away, right? Like if my paycheck is coming from that provider and that provider is just like on telling me how to do exams, I'm probably gonna pretty quick.
All right. So I was going to wait till the end of the program for this, but everybody's blowing up the social media stuff. So might as well just go ahead and do it now. If you're not aware, today is our friend's birthday. So
Thanks, guys.
happy birthday to you. Happy birthday to you. Happy birthday.
Oh my God.
Christine.
Thanks for all making it weird.
Happy birthday to you.
Thanks, guys.
All right. We can move on now.
Right
Let's
on.
get on to our next topic. So, Scott, I'm going to throw you into the center box, and I'm not singing to you.
Thank you.
Telehealth services. Let's talk about what's going on, because I know you had an issue that came up with telehealth services. Now, let me just kind of set this straight real quick. A waiver under the public health emergency does not mean that there are no guidelines. A waiver means that there are flexibilities. Okay? And those flexibilities have limitations. So, Scott, let me kick it over to you.
So where to begin with things I've seen and not seen in telehealth services? Some of the things I think we've covered broadcast concern the location of the patient versus the location of the provider and whether or not the provider is licensed to provide services in that state. So I won't go through all that again. I see plenty of telehealth encounters where they have not definitively established that they have a synchronous video connection within the documentation. In fact, sometimes they establish that they don't. I've seen things that say, well, the patient couldn't get the video to work, so she called. Or, the video broke down 5 minutes after we started, so we did the rest of it phone. All of these different things where the provider just goes ahead and bills a code. So I'm not sure where to even begin with that, because particularly as public health emergency goes away, we're going to run into some real issues, right? We know lurking down a certain sort of cooling off period before the public health emergency truly goes away, but lurking somewhere behind that, there are going to be issues related to originating sites for Medicare patients. It will not be absent some additional action, the free-for-all it's been before. I'm doing, even when the provider rightly switches to telephone-only coding, there's then a restriction on when the patient can be seen face-to-face within that window of time, which is really, I think, intended to prevent the provider from billing a phone call of results or something like that. And so I see those things. And I think there was a sense during the pandemic, particularly when it first started, that we ran 100 miles an hour at just like, we have to do things to enable patients to be able to be seen and keep people safe. So we're going to put in this public health emergency, both at the state and federal. But I think, that begat this little bit of a wild, wild west of just getting people on the telephone, getting people on, video. And when I'm auditing telehealth services and I go look up certain payers will say during the public health emergency, if the patient, then they can still bill an E&M service for a phone visit. Medicare does not. Certain states had their own public health emergency rules that were very different from the federal public health emergency. So I realize this is a lot, but I think it's all going to start to come to a head, and fluency is going to become an issue because it's a lot easier to get somebody onto telehealth than it might be to get them in the office. So my concern is that the next frontier as we get away from the public health emergency is going to be overall volume utilization, right? Like if I was seeing you prior to the pandemic, prior to this notion of telehealth, and now it's like I can get you on the phone all the time, there are going to be some problems. Congress may assist with some of it, but sorry, I sort of emptied the bag on that one. But there's just a lot, and it's a lot of sort of quiet, stealth.
Yep. So, Christine, let's talk a little bit about it. So, let's talk a little bit about with you and Terry and Paul. Let's talk a little bit about what's going on with HR House Resolution 4040, right? Because that's obviously something that was passed in the House of Representatives, and it now, or when it was passed, it was sent up to the Senate in the upper chamber for them to, debate it, pick it apart, send it back, or put it to the floor to a vote. So where are things at right now with that?
So we don't have even a date yet to put it up for a vote. We're still working on it. Like you said, the House has passed that. And that's to make some of those changes primarily from a Medicare perspective, because the Medicare benefit is the one that is so tough about originating site and the location of the patient during that visit, and whether it's synchronous or asynchronous, and the states that you live in. So just trying to get past those boundaries there. I know that they have opened the doors for hospice. We are trying to find some audio only solutions. It is a struggle. We're also looking at PT, OT, ST being able to provide some of those services long term after the PHE, still under telehealth. So basically, we've gotten nowhere. We're still waiting. We're still working forward. I mean, I think we're better than we were before because we're talking about it. But, the truth is, once we officially lift this public health emergency, there's no picking up the phone or doing a two-way with Myrtle anymore on her telehealth visits.
Well, and one additional thing that I guess I didn't empty the bag is, what is the nature of the device or mechanism of telehealth, and is it HIPAA secure?
Right.
Because that was another part of this exception where people were doing like FaceTime, and that was okay.
Right. And actually not addressed, though, Scott, in the CAA, the Appropriations Act, the Consolidated Appropriations Act, for the 151 days after the fact. They don't even address HIPAA, which surprises me because, again, that's under the flexibility where it's not that HIPAA went away. It's that you're not getting penalized as long as you inform the patient when you use something like FaceTime or the Skype that this may not be a secure line. My concern is that these House bills, and let's face it, I think that's what, the fifth one, Christine. There's so many that have tried to gone through. They're trying to push them through.
There's two of them that they've kind of consolidated together, but
Right.
based on what you're saying there, Terry, I think that people misunderstand that the using FaceTime or using Messenger, that's not actually waived under the 1135 section of Social Security. That's just a blind eye that Health and Human Services said they were going to do during the public health emergency. There wasn't anything that was officially changed, lifted, ruled, that we could use those products. They just said we're going to turn a blind eye to those products.
Well, and remember that's actually a great segue into the fact that once the PHE is formally lifted, because even though Biden said that there's no public health emergency anymore, the PHE still exists until right now, until October. But since there wasn't this 60-day notice, which I posted something yesterday out of frustration, I don't understand why there has to be a 60-day notice. Every time there's a 90-day renewal, that's your notice. So it doesn't make sense to me why you need another, a 60 days within that 90 days. If it's only for 90 days at a time, there's your notice. But this is, obviously this is about money because you're getting a 20% bump in a hospital if you still have the COVID diagnosis. So under the PHE, once the PHE goes away, that changes. And also they're also getting ready to make the vaccines now where that has to be paid for through either your insurance or the public. But that aside, let me come back to this. One of the things that is interesting that people aren't understanding is, especially for the ones that are proponents of free-for-all telehealth, which drives me crazy. And I love telehealth, don't get me wrong. I think it has a place in the delivery of medicine. Absolutely. Mental health patients, I think it's been just absolutely wonderful for mental health patients. And I see that we do have some permanent changes already that have come into place. Under the Appropriations Act, they put on hold that 6-month in-person visit, which I think was a mistake, but okay, but then you have to have that. But things that people don't look at is that the small print in the rules. So for example, telehealth audio only from the 99441 to 99443, those are going away once the PHEs ended. Do we have an alternative? Yes. We have a G code, and remember that's a Medicare temporary code, and to me I call them G, we're watching you, because they track those. So the G2252 is an 11 to 20 minute audio only, which they are going to allow, but the fine print says if the physician is unable to see the patient through audio and video. We already have virtual check-ins, okay, G2012 and G2010, and those don't have anything to do with the public health emergency. But moving away from the PHE under the Appropriations Act, now a point to Christine made is that you may not be able to use the FaceTime and the Skype, because even though they're extending telehealth, they're not extending the waiver under telehealth. They're only extending the use of telehealth. So when you read it in its entirety, which I did, and it made for really good bedtime reading several nights in a row, it basically is saying that they're still going to allow it to be paid, but they don't mention those platforms like they do under the waivers, which makes us to have to look at the fact that it would probably have to be the Microsoft Teams, the EMR option that you have, the secured, DoxyMe. So it would have to be more of those secured platforms instead of the non-secured, because I like how Christine put that and Scott put that. Those were the blind eye. Under the waivers, you know what? This is, what you have here. But here's another thing under the telehealth or mental health. You also have to have, and it's a modifier. And it was let me make sure I have it here, the FQ modifier. And that's the audio only when the provider is not available to participate via audio and video. Mental health services and behavioral health services are important to have that personal touch to it. And so audio only doesn't do that. But the reason that audio only is going away, and we can cite you all kinds of regulation on why, and this is in the own words of CMS, when you bill for a service that is considered to be equal to an E&M service, it has to be equal to. That's why they allowed the parity on the E&M with the audio and video. So that's why they allowed that. But once you take out that video portion, you don't have that in-person effect. It's audio only. You don't even know if that's the patient unless you recognize their voice. And so there's some problems there with that. And that's why they're limiting also how much you get paid if you do audio only. But the last thing I'll say on this, just because obviously it annoys me because of what's going on there, is I wish they would fix or at least expand broadband and the option for rural communities to be able to access telehealth before they expand usage of telehealth. These Senate bills, these House bills, to me, it makes no sense to do that while you have MedPAC and you have OIG working on why there could be fraud, waste, and abuse on this and how easy it is to manipulate telehealth, as Sean mentioned and Paul mentioned. But to me right now, let's make sure that we have, aren't we all trying to figure out medical parity and equity? If you have people in, faraway places that can't even access telehealth, why are we expanding it for everybody but them? That makes no sense to me.
Yep.
All right, I'll stop.
I agree. So, Christine, the last thing I want to talk about on telehealth, tied to mental health services, behavioral health services. Are patients required to have the interactive portion, meaning the video portion, in order for a provider to then be able to bill for the telehealth service for behavioral health?
That's a great question. So one of the things that the final rule last year gave us was some guidelines on their expansion of telehealth for telemental health or mental health services performed via telehealth. So they told us that the providers got to have the two-way ability. So that's not changing. And so they'll need to have that HIPAA compliant two-way ability. Now, if the patient doesn't have the ability, or maybe the patient doesn't want to, maybe the patient cannot, maybe they're in that rural area, then it's got to be documented why the patient couldn't participate in the audio video. And then, like Terry said, we've got to use that modifier to indicate that it was just an audio only visit. And they told us, we want you to use the modifier so we can audit you. So we can see if you're doing it right, or if there seems to be, maybe that's the preferred mode, or are we finding, just to calculate data. I didn't mean to say audit like so, but I warned you guys.
Right.
But that's where it's going right now. That's where we're at.
All right. So I want to shift to our last topic of the day. And I think this one's going to take us probably right to the end of this thing. So before anybody goes, oh God, not again. Yeah, we're going down the rabbit hole of Incident 2 services, because the issues surrounding Incident 2 billing services continue to create issues for provider groups, for hospital networks, for integrated delivery health systems. Again, I gave multiple lectures over the last 10, 12 days that I was on the road between Denver and Fort Collins and Loveland and Portland and Dallas and Waco. And I will tell you, no matter where I went, there were misunderstandings, misperceptions, flat out wrong information on Incident 2. And I gave a little bit of a teaser before we got started to where I said physicians billing under other physicians for Incident 2, and then whether or not. So let's talk about this, right? Because the CMS benefit, the Medicare Benefit Policy Manual, which is Chapter 15, and it's found in Section 60.1, talks about Incident 2 physician professional services. So, as we all know, Incident 2 of physician's professional services means that the service or supplies are furnished as an integral, although incidental, part of the physician's personal professional services in the course of diagnosis or treatment of an injury or illness. I think we're all on the same page, right? Now, these services, again, for it to be Incident 2, they have to be commonly furnished in a physician's office. Okay? And they are covered under the Incident 2 billing provision. So, for Incident 2 to be met, it requires what type of supervision? Anybody?
Direct.
Thank you. Direct.
Direct
Okay, so we're all on the same page. So when we talk about Incident 2 and we talk about direct supervision, right? This is direct supervision is limited to situations in which there is direct supervision. It's direct physician supervision of auxiliary personnel. So you've got to define the term auxiliary personnel. So let's do this real quick. So auxiliary personnel means any individual who is acting under the supervision of a physician, regardless of whether the individual is an employee, leased employee, or independent contractor of the physician, or of the legal entity that employs or contracts with the physician. The physician personally furnishing the service or supplies, or supervising the auxiliary personnel furnishing the services or supplies, must have a relationship with the legal entity billing and receiving payment for the services or supplies that satisfies the requirement for valid reassignment. Now, last couple points, okay? Where a physician supervises auxiliary personnel to assist them in rendering services to patients and includes the charges for their services in their own bills, the services of these personnel are considered incident to physician service if there is a physician service rendered to which the services of such personnel are an incidental part and there is direct supervision by the physician. So this does not mean, you see I keep using the term direct supervision. This does not mean, however, that to be considered incident to, each occasion of service by auxiliary personnel need also always be the occasion of the actual rendition of a personal professional service by the physician. Direct supervision in the office setting does not mean that the physician must be present in the same room with his or her auxiliary personnel. However, the physician must be present in the what?
In the office setting.
In the office suite and immediately available to provide assistance and direction throughout the time the aide is performing the services. Now, Robert Lyles and I, for those of you that don't know Robert Lyles is just a wonderful human being. He's a brilliant attorney. He's the former deputy director at the Department of Justice. All of the attorney generals in the United States actually reported to him when he was at the DOJ. He's just unbelievable. So 2 questions came up. 1, can a physician work incident to another physician? So rather than asking that question and trying to solicit responses, I'm just going to tell you the answer is yes. A physician can actually perform incident to services of another physician.
Do not hang up,
The
people.
fact
You
that-
have to keep listening to what Sean's saying, because there's
Yeah.
but. There is a but. I don't want anybody to hang up
Yeah.
and go, Sean said, now there's a but. Go ahead.
Yeah. So let's talk. That's right. So let's talk about this, because it's important to keep in mind that there is no national policy under Medicare law that precludes a physician. And when we talk about a physician, I'm talking about a medical doctor or a doctor of osteopathy who is enrolled under Medicare and participating under the program from having the services of another physician provided incident to his or her professional services. Here's the reason why. The fact that the physician who is serving as auxiliary personnel in this case is not enrolled under Medicare does not prevent the physician from providing incident to services or the Medicare enrolled physician from billing the program for incident to services. However, the incident to services must be determined by the Medicare contractor to be reasonable, appropriate, and necessary. And all of the incident to requirements have to be met. Now, I've had folks that have emphatically stated in the past, you can never have a physician perform incident to services under another physician. They were emphatically wrong. You can. Okay? If you want to know where this information resides, I'm going to give it to you. The first is under 42 Code of Federal Regulations, section 410.26A1. 42 CFR 410.26A1 under auxiliary personnel. Now, the second question that came up, and this stumped even some of the folks who are my trusted resources, because this was another stumper. The second question was, can a nurse practitioner or a physician assistant who is not credentialed with CMS provide services incident to a physician who is credentialed? So this answer was puzzling, given all the guidance that's been provided by Medicare administrative contractors over the years, to where they have stated unequivocally, in order to be billed as an incident to service, you have to have your providers enrolled. The fact is, you don't. Nurse practitioners and PAs who are not credentialed with Medicare can still render services under the definition of auxiliary personnel. And those services can be billed by a credentialed physician under Medicare regulation. So keep in mind that this long-standing regulatory definition for auxiliary personnel does not require that when providing Incident to services, NPs, CNSs, PAs, or any other individual with a credential, nothing requires them to be enrolled under
However-
the Medicare program.
Let me jump in for a second.
Yeah, we're gonna
But
get
how awkward?
Go ahead.
Oh, sorry, Terry. How
No,
awkward
you're
would it be for the patient when the patient says, my blood pressure is not at goal and it's not in the treatment plan. Can you increase the meds? Can you send me to the doc? Wait a minute, let me go and get somebody who's credentialed with Medicare so they can get paid for this visit because I'm not credentialed and Incident 2 is not being followed. That's going to be really awkward in a practice. I'm not so sure that's going to fly real well with your Yelp reviews when you can't continue on a visit. You've got to bring someone else back in.
Right. And to another point, CMS has verified that it might, and I'm going to say might because they put this on their podcast in one of their stakeholder meetings. It might be necessary for a physician to bill Incident 2 services provided by another physician, but they said it is a rare circumstance. And if we find it, we will audit it. So even though, I know you're putting out the technicality of the rules, I really believe that we have to tell people, do not use this as a standard of care, because a lot of practices will hear what you're saying. And even though you did mention it, they'll say, oh, good, I'm hiring a new physician and we haven't got them completely credentialed yet or with the payer. And so we're just going to bill everything under another doctor. And please don't do that.
So that's a great point. So let's talk about that for just a second, right? So when we're talking about Incident 2, we've got to be crystal clear. This is only a Medicare term. Don't try to use Incident 2 from Medicaid. Don't try to use Incident 2 for your commercial payers. It is a Medicare specific term. I agree with you, Terry. This should not be a regular occurrence where for an extended period of time. But just so you know, the person who actually writes the Federal Register on behalf of the Centers for Medicare and Medicaid Services, and her title is Centers for Medicare and Medicaid Services, Center for Medicare Health and Ambulatory Policy Group, Division of Practitioner Services, is the main source who actually writes within this. Listen, I know people don't like this exception. I get it. I understand. The problem is we can't speak in absolutes by telling people you can never bill a physician under another physician when the regulation actually says you can. I don't like it myself personally.
You can, so we have to be clear on
Go
that.
ahead.
We have to, the
Say that one more
regulation
time.
says it's rare that you can. It doesn't say that you can in a matter of practice. So if there's an exception in your office where you have to call in another physician and they're going to bill out their services under a physician who's there that maybe doesn't have that same expertise, okay, that's an exception to the rule. But I would hate to see any of the listeners or anybody watching today that would say, you know what, guess what? Now you can bill physician to physician. Now you can bill a non-credentialed person. And to Christine's point, it's not best practices. We don't want to do that. So hopefully, Sean, you're bringing it to their attention that technically, if they had to prove it in court, they would have backup under, the policy manual, chapter 15, section 60, the processing manual 100-04, chapter 26, 1004, and plus the federal regulation 1426. I have all that too.
Have that answer.
Don't do it.
Like you said, Terry, have that answer of why, if you are having direct supervision by the physician who is there, who is credentialed, who is following the Incident 2, why couldn't they see the patient? What was that exception? So, I would document that too.
So a couple of things. Let's just wrap this piece up here. So a couple of things, keep in mind. Even though the guidelines state that you can bill physician to physician or you can bill another auxiliary person, under a credentialed provider. Under the guidance manual, you cannot bill a new patient as incident 2. There is no billing a new patient as incident 2. They have to first be seen by a physician who has what? Established the care of the patient. The point that I'm trying to make here is because I've been involved this year in 4 criminal cases where incident 2 has been a focus, where the government has come in and they have given some guidance from who? The Centers for Medicare and Medicaid Services. But what they used were guidance documents. And when we use guidance documents that have not been put through a formal rulemaking process, even though it comes from Medicare, it is still a sub-regulatory guidance document. A regulation is what you would find under the Code of Federal Regulations, which is 42 CFR 410.26A1, where they define auxiliary personnel. So the bottom line here is this. It's not a best practice to go and bill physician to physician. If you do it, it should be in limited situations. Number 2, if you are billing a nurse practitioner, a PA, or CNS under a physician and they are not credentialed, you really need to get them credentialed, because incident 2 billing guidelines are so complex, they are so problematic, and they are highly investigated by the Office of Inspector General, by the Centers for Medicare and Medicaid Services under audit. Again, I know this frustrates folks, but the regulations are the regulations, and it is a permissible service as both that we were talking about. All right. Now, Christine, last thing that I want to talk about are collaboration agreements, because there are state regulations and laws that come into play. Let's talk about those quickly.
So I had a client recently reach out to me, and it's a really large organization. So I was super surprised when they asked the question. So as long as we have a doctor in the suite who supervises all the nurse practitioners and co-signs all the notes, we bill everything under the doc. And I was like, where did that come from? Where do you get these ideas? Who said that this was even remotely possible, right? So we go back to that collaboration agreement, like you said, some of the states have, and it's different for PA and NPs. And I'm in the state of Florida here. And those collaboration agreements are fill in the blank. What's your collaboration agreement going to be? Do you want to audit that provider? Do you want to, co-sign their notes? But that has nothing to do with billing agreements or what you agreed to in your contracts with your payers.
That's right. That's right. All right. So this is going to bring us to the end of our compliance roundtable. We missed y'all significantly and seriously last week. I hate that we weren't able to do it, but folks, I was on literally 10 airplanes in 12 days trying to get from one place to the other, to the other, to the other. We're back. We'll be back again next week. Thank you all so much for tuning in, logging on, and just hanging out with us. Thanks for making Christine's day special for her by wishing her a happy birthday. You don't look a day over 22.
That's the goal.
All right, y'all. The compliance guy will be back tomorrow with our hashtag Terry episode. Join us, because I know it's going to be a lively discussion, as it always is between Terry and I. I'll be back on Wednesday, Thursday, and Friday this week with Daily Dose episodes, where I'll be coming to you live from the American Health Law Association meeting in Baltimore, where I'll also be presenting. So with that said, thank you all again. And until tomorrow, be good to yourself, but more importantly, y'all be good to each other. Take care.